Okay, so we're going to get started with acute respiratory distress syndrome, or ARDS. Our learning objectives. Going back to our normal gas exchange unit. So with ARDS, results in severe dyspnea, hypoxia, decreased lung compliance, diffuse pulmonary infiltrates, and that's actually like the key finding, because usually with an infiltrate, if there's like an empyema, like an infection in the lung, it's usually just a pocket, like an isolated pocket, or if it's pneumonia, pneumonia likes to favor the the right lung, usually like the right middle lobe or the right lower lobe. But with ARDS, it's diffuse, meaning that it's like widespread. This is an acute form of respiratory failure, and it's usually very sudden and then very progressive. So it doesn't really have an insidious start. It kind of comes on pretty fast. As the alveolar membrane, as we see in this picture here, so you have that interstitial space, and you can see it's starting to fill with fluid. That fluid actually creates pressure, and that membrane starts to become damaged. And when that happens, it just makes it more permeable to fluid, and eventually the fibrosis and the scarring of this tissue make that area no longer able to participate in gas exchange. Moving on to our case study. So we have an 82-year-old woman. 4 days ago, she aspirated her lunch. And when we see aspirated, aspirated can be anything really. You can aspirate liquid, you can aspirate food. What happens is that whatever it is that's aspirated, typically will cause an infection in the lung. Any type of like foreign object. So we have her diagnosed with aspiration pneumonia. She started on antibiotic therapy of Zithromax. Some initial assessments that we want to gather on her. Obviously, we want to do her level of consciousness. We want to get some vital signs, lung sounds. We want to maybe put her on an EKG monitor and see what her heart rhythm is doing. Skin color, temperature, depth and effort of breathing, those types of things we're going to want to assess. So we see that she's developing progressive dyspnea and restlessness. We know that restlessness and agitation are early signs of hypoxia. And she's also confused and agitated. At times she's gasping for air, and then we see our chest x-ray that's now showing the diffuse infiltrates. So we know a primary cause of this was her aspiration. Risk for ARDS includes age, infection. Hold on, my cat. Okay, cat's been evicted. So priority of care, obviously we're gonna go back to our airway, breathing, circulation. So looking at the etiology and patho, I don't really want you to focus too much on this. I know looking at this, it kind of looks a little scary, but we can break it down. So pulmonary capillary membrane permeability. So what this means is that when that's increased, there's more free-flowing fluid. So fluid's able to get into those alveoli and disrupt that gas exchange. Destruction of elastin and collagen just, contribute to decreased elastic recoil of the lung. So once it's stretched open, it has a harder time of snapping back, and for ventilation to occur. Formation of pulmonary microemboli, so these, would be those small clots in the lungs, some tiny PEs. And then pulmonary artery vasoconstriction. This would prevent blood from getting, that deoxygenated blood from getting to the heart, to the lungs to participate in oxygenation. So I do want you to focus on these phases. Okay, so with our phase, phase 1, our injury or exudative phase. So this is 1 to 7 days after the initial lung injury or insult. So there's that damage to the endothelium, which increases that capillary permeability. This allows that fluid to go into that alveolar space. Those alveoli fill with fluid, and then blood passing through cannot be oxygenated. There's no problem with perfusion at this point. It's just that fluid, that diffuse limitation that's preventing that oxygen from going into the blood. And then additionally, there's also decreased surfactant production as well. Now, surfactant is helpful in preventing atelectasis. So on exhalation, it prevents those alveoli from snapping closed and not being able to open back up. It's what's given. I know you guys haven't had OB yet, but it's what's given to preterm infants to prevent that from happening with them. Okay, so the primary symptoms of this are going to be that alveolar edema. So your initial assessment finding is going to be, crackles in the lungs. The chest x-ray is going to show those diffuse pulmonary infiltrates. So there's, a lot of like dead space. There's less areas for gas exchange to take place anywhere where there's the fluid accumulation. This causes a severe VQ mismatch and then shunting of pulmonary capillary blood, which results in that hypoxemia. Another key finding of how we know that this patient is potentially going into ARDS is that they're unresponsive to increasing O2 concentrations, because no matter how much oxygen we give them, if there's less areas for gas exchange to take place, it's not going to help, because that fluid is blocking that oxygen from getting to the blood. Lungs do become less compliant. So in this way, the patient, that whole gasping for air that patient was doing before, this is because that airway pressure needs to be increased because there, the loss of elastic recoil and decreased compliance. Just taking those, deep, hard breaths to try to get air in becomes very difficult to breathe. Okay, so in that injury exudative phase, we're going to hear those crackles, increased work of breathing, depth is going to be shallow. Even though they're trying to take a deep breath, it's hard to because of that decreased compliance. Increased respiratory rate, decreased tidal volume, which is essentially how many millimeters of air you take in with each breath. So that would be going down. And then decreased tissue perfusion. Some additional vital signs we're going to see might have some tachycardia, some mild hypertension, and then cognitively might have some restlessness, agitation, confusion. So going back to our patient, she's been in the hospital for 1 week. She's been diagnosed with ARDS, started on IV antibiotics and oxygen therapy, but continues to struggle to breathe. Her O2 is 88% on 6 liters via a face mask. So moving on to our reparative or proliferative phase. So what this means is that some patients just, spontaneously that membrane is restored, that fluid is reabsorbed, and they start to get better, whereas some patients, it progresses. So this is going to happen 1 to 2 weeks after the initial lung injury. With that fibroblast proliferation, the lungs become more dense, thicker, more fibrous, less areas for gas exchange to take place, and then lung compliance also continues to decrease. If it does enter the proliferative phase, hypoxemia of the patient worsens. If this continues, then widespread fibrosis would result. If the phase is stopped at this part, if they go into the reparative, those previous lesions that they had already formed in injury exudative, those actually do start to resolve. So in our fibrotic or chronic late phase, so this is if the patient went into the proliferative phase. The next step after that is the fibrotic or chronic late phase. So this is 2 to 3 weeks after lung injury. The lung is completely remodeled by collagenous and fibrous tissue. So decreased lung compliance, decreased areas for gas exchange, hypoxemia continues. They might have some pulmonary hypertension. And with this, the diffuse scarring and fibrosis results in, overall decreased lung compliance. At this point, we're looking at long-term mechanical ventilation, because if your lung is completely remodeled by this tissue where gas exchange can't take place, a ventilator, a long-term, like a long-term acute care facility like an LTAC, where the patient would need to be on a ventilator to generate those high airway pressures and essentially force the oxygen into the patient's body to meet the body's needs, because the person on their own isn't able to take breaths enough to have that oxygenation take place. If that makes sense, I'll explain it a little bit more later on. So progression of ARDS, it does vary among patients. Some risk factors I talked about before are age, if they have an infection, if they have poor wound healing, any other types of comorbidities. However, it's not known why some persons, they repair and recover, and in others it progresses. So some things that additionally will affect that would be like if they have any pulmonary complications already, if they've had, pneumothorax, history of asthma, COPD, those patients, their chances are, to go into the fibrotic phase. So going back to our case study, we've got our patient. She's working hard to breathe. She's got those diffuse crackles, pale and diaphoretic. You can see her vital signs are representative of her being, hypoxic, and just the overall body being stressed out. We can see that her heart rate is trying to compensate by pumping more blood, pumping faster to get that blood to the lungs. But it doesn't really matter since they're not, participating in gas exchange, and her blood pressure has gone up as well. So when looking at diagnostic tests, definitely going to want to get those ABGs, that gold standard. Chest x-rays should be ordered, routinely, and this way we can track, to see what those infiltrates are doing, if they're starting to resolve or getting worse. And then a pulmonary function test. This test is helpful. It allows us to measure lung volume, so that tidal volume, capacity, the rates of flow, and overall gas exchange. So PFT would most likely be ordered, potentially a VQ scan if we're suspecting those microemboli. And then the next step in treatment for her would be mechanical ventilation, because she's going to tire out pretty quick. She's working hard to breathe, and her respiratory rate is being sustained at 32. So we need to give her a break, give her a rest, and start getting her oxygen via another method. So some late manifestations, although you will see some tachycardia, diaphoresis, changes in mental status early on, you're also going to see those late as well. Then comes the cyanosis and pallor, diffuse crackles and coarse crackles. So with those crackles in the lungs, you're going to hear them, throughout all fields. Those coarse crackles are basically the same thing, except they sound even worse. They sound, I've heard them called junky before. It's really hard to describe how they sound. It's almost like, the example I gave my students before was like if you were blowing bubbles in syrup, and they laughed at me and were like, "Who blows bubbles in syrup?" And I was like, well, I'm trying to help you. I'm trying to give you, like, an idea of what it sounds like. So you could imagine if you're blowing bubbles in syrup. And hypoxemia despite increased FiO2. So FiO2 is a fraction of inspired oxygen. It's typically a setting that we see on a ventilator, and it's in a percentage. So our room air is 21%, approximately 21%. So as we increase our FiO2, their hypoxemia worsens, which in general, when we increase FiO2, then our pulse oximeter goes up, our PaO2 on your ABGs goes up. And then we've got our increasing work of breathing, despite initial findings of normal PaO2 or SaO2. So this is a good picture of a whiteout lung. So Whiteout lung is basically when there's those diffuse pulmonary infiltrates. You could see the areas here where there's few recognizable air spaces where that's, so looking at the all of the infiltrates that are through this lung, gas exchanges isn't taking place in those areas. So you can see this person's ability to breathe is cut down. I don't even know, maybe like 50–60%. So you could see why that patient would be tachypnic, why they would be, taking some shallow breaths and, have that tachycardia as well. So some complications that could happen, so volute trauma. So this would be on a mechanical ventilator. Once the patient's placed on a mechanical ventilator, the settings have to be determined to make sure that we don't overinflate the lungs, because if they are non-compliant from that fibrous tissue and we try to put too much air into them, we can actually cause some damage to that tissue. So we want to make sure that we're going to be giving them smaller tidal volumes, that amount of air that the person is inhaling, or even doing like a pressure control ventilation. And what that would be, and we're going to talk more about this, we're going to go in depth when we talk about mechanical ventilation, but with pressure control, there's a set peak inspiratory pressure setting that is done. And basically that's saying that once that pressure is met, any additional air that the ventilator was going to give, it's not given to the patient, it just spills over into the environment to make sure that we don't overinflate those lungs. So barotrauma, so this is so it's very similar. This is too much pressure. So this can cause those rupture of the overdistended alveoli during mechanical ventilation. So again, we want to ventilate with smaller tidal volumes to make sure that we don't cause barotrauma, and make sure if we're doing a pressure control ventilation that pressure isn't set too high. Some other complications we might see, so decreased renal perfusion and subsequent decreased delivery of oxygen to the kidneys. So if the kidneys aren't getting enough oxygen, a patient could go into renal failure. We would see our BUN and creatinine elevated. Urine output would decrease and it would be concentrated. And this would be, if you remember from second semester, this cause would be like a pre-renal failure. Stress ulcers, so the body, it sacrifices the kidneys, it will also sacrifice the gut. So bleeding from stress ulcers might occur in 30% of patients. So if there's an issue with that, we can give some anti-ulcer drugs. The most common is going to be your PPIs, your proton pump inhibitors. And what I see very frequently given in the morning is Protonics, kind of a daily thing to prevent stress ulcers or peptic ulcer prophylaxis. Okay, so for our nursing assessment, we want to do a complete respiratory assessment. We want to check the use of accessory muscles, the rate, rhythm, depth, and effort of breathing, the chest expansion, lung sounds. We want to check for, the heart rate. So if they have tachycardia, if it progresses to bradycardia, that's essentially the heart's compensatory mechanism kind of failing at that point. Same thing with hypertension progressing to hypotension. Pulsus paradoxus, so this refers to a fall in a patient's blood pressure during inspiration, and it's got to be greater than 10 millimeters of mercury to be considered pulsus paradoxus. JVD, pedal edema, abdominal. Again, anytime the kidneys, if they start to have some kidney failure, then we have some fluid retention, and this can result in some fluid accumulation in the body. Abdominal distension, ascites, and then somnolence, confusion, delirium. Somnolence is just essentially like sleepiness. And then additionally, we're gonna have changes in our ABGs as well. Okay, so for our strategies for ARDS, the best position for ARDS is actually prone. Reason being, if they are on their stomach, it allows for full airway expansion. It helps prevent that atelectasis, and it also keeps pressure off of the heart and the lungs than if they were supine. So here is a prone bed. You can see the areas, the open areas to allow for lung expansion. Here's a roto-prone bed. So this allows nurses, physical therapy to place patients in the prone position. And it's not specifically indicated for treatment of ARDS or VAP, but it could, VAP, sorry, is ventilator-associated pneumonia, but it could help with that. This was the best picture I could find. I know it's not the greatest, but I think it demonstrates, the point very well. So continuous lateral rotation therapy, so CLRT. So this is a side-to-side turning of the patient, rotating the bed 40 degrees. So this prevents fluid from pooling in those dependent regions of the body. And it's also very quick, so easily and quickly. We know in the healthcare setting, turning a patient sometimes can require, a few people and finding those people, and then eventually, being able to turn them can take some time. So this is a very effective method. So we really want to make sure that we maintain our perfusion and definitely our cardiac output as well, because if we're already having problems with oxygenation, it wouldn't be good if we're also having problems with perfusion as well. So we want to make sure that we're paying attention to that. Patient might need some crystalloid fluids. And when you hear crystalloid solution or crystalloid fluids, that's just your normal saline, your lactated ringers, your half normal saline, your D5 half normal saline. If you were colloid solutions, that's going to be your albumin, any type of that strong protein that pulls fluid into it. So we want to make sure that we're maintaining that blood pressure and that cardiac output. Some other drugs that we could use would be some inotropics, which stimulate that contractility of the heart. They make it more effective at pumping. So that would be like your dobutamine and your dopamine, and we'll talk more about that when we get into mechanical ventilation. And then additionally, we might need to give some packed red blood cells, some PRBCs for that hemoglobin. Going down to nutrition fluid balance. So it's again, enteral or parenteral feedings. If a patient's mechanically ventilated, they have an ET tube and they cannot eat PO. So we have to do, typically we'll do like an OG tube and we'll hook that up to the ET tube. An OG is an oral gastric tube. It's the same thing as an NG tube, except it goes in through the mouth. It's attached to the ET tube to stabilize it, which is really nice because then those are very secure. ET tubes are very secure, so unlike an NG tube, which is just kind of secure to the nose. And then we're going to start some enteral feedings. Enteral are preferred over parenteral. Parenteral is given through a central line like your TPN, total parenteral nutrition, because we're still using the gut when we're doing enteral nutrition, so that is preferred. Okay, so for our evaluation, we want to, have no abnormal breath sounds, make sure the patient's able to effectively cough and remove secretions, normal respiratory rate, rhythm, depth, and effort, the synchronous thoracoabdominal movement, that's just basically if they had that paradoxic chest movement, that's been resolved. Appropriate use of accessory muscles, we want our ABGs to be within normal ranges, maintenance of weight or weight gain if they had lost weight, and then our serum albumin and protein within normal ranges. So additionally to this, we want to make sure they have urine output minimally greater than 30 mLs per hour, no edema or potentially like trace edema that's resolving. All of those things are going to be like our expected findings for the patient to have recovered. So when assessing a patient with sepsis, which finding would best alert the nurse to the onset of acute respiratory distress syndrome? Okay, so take a moment, read through your answers. You can pause this. Okay, so your answer for this one's going to be C. So SpO2 of 88% doesn't really let us know that the patient's going into ARDS. This could just be a patient with pneumonia, COPD. Use of accessory muscles of respiration. So again, this could really be anything. This could be an asthma attack. And then going down to our ABGs, when we look at that, this patient is slightly respiratory acidotic. However, their O2 is within normal parameters. It's low. It's right at that 80, but you know, it's still okay. So our best answer is going to be diffuse bilateral crackles on auscultation of the chest.